16-year-old female volleyball player sustained a left shoulder injury while spiking the ball during a tournament. She continued to play despite shoulder pain, 5 out of 10. Claims that she noticed a decrease in striking power and accuracy. Imaging was negative for shoulder dislocation and bony pathology. She now comes to PT 3 days after the injury, with a prescription asking you to rule out slap tear and to treat accordingly. You are asked to treat this patient for a safe return to volleyball activities.
Wow, I'm really a good writer.
Based on the patient's level of activity and age, what type of slap tear? Where do you said number 2?
You said it's, okay, what's a brief explanation of this slap tear? You say number 2. Everyone will be talking, correct?
Yeah,
Okay.
don't worry, we got a whole thing.
You got a whole thing,
The
okay.
whole thing. Number 2, overhead use superior labrum to detach from the bicep insertion. Active individuals who perform repetitive overhead movements like we saw in this.
So type 2 affects the bicep tendon, yes or no?
Yes.
Yes, okay. And the activities that promote the slap 2 tear, you said are what?
We said overhead usages of overusages of overhead activities.
Repetitive
popping,
overhead, yeah, go on.
or deceleration during throwing, such as in volleyball spiking.
All right, just talk slower, just because so that people can study. So put that on.
Looks
Oh, you
like
can
Eric
slow. I'm
Stenson.
old.
Wow.
Sorry, I didn't. Okay. Yes. So repetitive overhead movement, deceleration phase of the volleyball spike. That all is good. If it's not an active individual, a person would come to you with a slap 2 lesion from what? Forward foosh, right? Foosh.
Forward.
For the written, you have to know all the slaps. For this one, you only have to know the type 2 slap, okay? Name all the sport-specific deficits this patient is experiencing.
We saw loss of function, including striking power,
Yes,
throwing velocity,
yes,
target accuracy,
very good.
and level of consistency. Trouble spiking the ball hard and accurately, loss of endurance with spiking.
You sound like an AI.
Excellent. So striking power, throwing
Slow
velocity,
down.
and target accuracy.
So-
Very well said. Yeah, I think you have a voiceover career ahead of you.
Yeah.
All right, now manual muscle testing. The patient has a weak core. Why? Because all overhead activity comes from the core.
Yes.
So in Kines, did you learn how to do a core?
Yes.
Show us one.
I'll show you real quick.
Show us
There's
quick.
levels.
You need
There's
the paper or
levels.
you good?
Supine. This is the first level. Hands on the table.
And they have 5 out of 5 if they can do what?
Behind the head.
Okay.
Bringing your elbows forward.
Oh yeah.
All right. So yes. So that is. So the patient has weak core. You're going to have to know how to perform the weak core. Now, what specific rotator cuff muscles are weak, or what range?
But this is going to be external rotation.
External rotation is weak. Again, you're going to have to show us how to manually manually muscle test the external rotators. We don't have to do it now, but you're going to have to know how to do it for the practical exam. You take the person's shirt off and you observe their scapula, right? What would you see?
So you're going to see scapular dyskinesia.
What is scapular dyskinesia?
The midline border or the inferior border is going to move posteriorly when you flex or abduct your
So medial border or the inferior border pops off the thorax. Very good. And what muscles are weak when that happens?
the serratus anterior and the rhomboids.
Serratus anterior and rhomboids. Very good. Range of motion testing. So for this, you have certain capsular, right? Because this patient has specific capsular tightness. Okay? What parts of the glenohumeral capsule might be tight?
The posterior aspect of the capsule.
Say it loud.
Posterior aspect of the capsule is tight.
So
and
posterior capsule is tight, and
the inferior.
the
aspect of
inferior
the
capsule is tight. So, when the inferior capsule is tight, right? Or when the posterior capsule is tight, that means that's going to affect internal rotation, right? Because internal rotation, it affects the posterior capsule. How could we do a test to show that they're lacking in internal rotation because of the capsule? It's called, what is that called, by the way?
The Hawkins.
It's called GERD. GERD.
Yes.
So how do we show GERD? The patient is supine on the table. Show us. And then you have the patient, let's say you look at their unaffected arm and they go, ooh, look at that, no problem. Then when you do their affected arm, you're gonna see that there is lacking significantly in internal rotation, right? But it's because of the capsule in this case. Because repeated overhead movement creates posterior capsule tightness,
affecting internal rotation, and that's known as GERD. Okay, not the GERD from, what is that GERD?
Invader Zim?
Not that GERD, a different GERD. Finally, what other part of the capsule is tight?
The inferior.
You gotta yell it.
Inferior aspect.
Inferior aspect, right? So you have posterior capsular tightness, inferior capsular tightness. The inferior capsular tightness is known as what? The inferior glenohumeral ligament. So that ligament is tight, that's the bottom part of the capsule, and that's why you have issues. So inferior and posterior, very good. Postural assessment.
Head forward, rounded shoulders up.
Just like Jackie.
Just like that.
You wanna have a guest lecturer? They'll be sitting like this, right? That's how they'll be sitting, very good. How would you teach this patient to fix this posture?
Shoulder blades down and back. Open up the chest.
All right, we'll get more into it, I think the last lecture of this semester. All right, now, special tests to rule in the diagnosis of type 2 SLAP lesion.
All right, so we're
Let's
gonna
do this
start-
properly, slowly, so everyone can
We're
see.
gonna start with O'Brien, I think. Yeah, O'Brien. So this is a passive test. No, yeah, it is. We're gonna start with full internal
There's
rotation.
a lot of Irish special tests, O'Brien, Kennedy.
Yeah. Full internal rotation.
Oh, is that the empty can? So wait, we're doing empty can, so, no, O'Brien is what? That's not called empty can to throw people off. First you do resisted flexion and full internal rotation, you provide good.
Push up?
Then you do resisted flexion and
Supination.
full supination or external rotation, no,
Oh yeah, yeah. Sorry.
resisted flexion. Which one will be more painful?
The one that with full internal rotation because the bicep is fully taut.
Right, so the answer is that you'll have more pain with internal rotation because it makes the bicep tendon taut. And when you provide resistance to a taut bicep tendon, which attaches to the labrum,
The superior.
that will cause pain. Does everybody understand that? Taut bicep tendon attaches to the labrum, providing resistance is a positive sign.
The tendon
Now-
is pushing on the
But isn't it easy if you understand how the anatomy works?
Yeah.
It's not memorization.
That one is a little bicep.
Right here, the bicep tendon is on slab. Now here, the bicep tendon is taut.
Because the bicep also do supination.
Bicep does supination. So when you go into pronation, you're stretching it. Got it? So it's taut and you're applying pressure. Very good. Next.
We're moving.
What's
Anterior slide test is also passive. The patient's hand on the hip, elbow to the back. Yeah, I didn't want to do that. I'm stabilizing here. He's gonna resist the motion, and I just push.
So he's pushing, and then when he's doing that motion, he's grinding what part of the shoulder? The anterior, the slap part, anterior to posterior,
Yeah,
superior
yeah.
labrum. So that, he's resisting that movement. A positive sign is
Pain.
pain.
Always pain.
Finally, is there another special
Yes.
test?
Yeah, it's a passive distraction test.
Who's doing it on the patient?
Just hold my arm in 45.
No,
I don't think
this is,
it's-
what kind of practice is this?
55.
So he's distracting my arm in 45 degrees, 55 degrees abduction, and that's gonna cause pain.
No, you're forgetting the internal
Oh, yeah,
rotation.
internal rotation.
What is
So you're passively bringing the patient to abduction and internal rotation.
Also in the
which does
slides, it says, there's a beta that shows you at 155, but all you need is 55, so.
Yes, so
whatever
you're
you
just,
use.
because this again makes the bicep tendon taut, right?
Yeah.
Abduction also makes it taut, and that if that's pain in the anterior shoulder, that could be a positive sign.
Yeah.
And how do we rule out bicipital tendonitis? Because it could just be the bicep tendon
Actually,
and not the labrum itself.
The speed test.
Speeds test.
I guess I'll go ahead. I have the patient holding out his arm.
90 degrees, very good.
Elbow extension. And they're gonna go ahead and try to raise their arm.
So wait, the patient doesn't know, what are you resisting?
You're resisting my pressure. I want you to bring your arm
No, you're
up,
resisting elbow flexion.
Are you
In
gonna
3
curl?
different planes.
Okay, so we're gonna start in the, wasn't
Well,
me.
it's not- same plane, 3 different ranges of motion. So you're not resisting shoulder flexion, you're resisting elbow flexion.
Yes, right? Good. I'm thinking
That's
flex.
one, you pick another range, part of the range.
You can do.
No, the shoulder stays where it is, you're resisting elbow flexion. Another,
Great.
now you can resist it over there. Good, and then another part. Good, so if they have a positive speeds, but they have a negative O'Brien's, what does that tell you?
You will just not.
It probably is not SLAP, but in fact it's bicipital tendonitis.
What was the one you did there? What was that test?
It's called passive distraction.
Passive
What's that?
distraction.
There's
The 3 tests are anterior slide, passive distraction and speaks to rule out bicipital tendonitis. Very good.
Just hold on.
Good. Red flag. What about myocardial infarction and shoulder pain?
So for our specific patient, she's a left-hand striker. So she might be having pain on the left side, which it can also be coming from the rotator cuff muscles and the neck, shoulder, and arm.
So, right, classic signs for heart attack is left-sided pain, right? So you have to know the patient's history. You have to make sure to rule out that if need be. Okay, are we good? We're up to treatment now?
Yeah.
Okay, so week 1 and 2, and then we're going to progress to week 3 and 4. Show us scapular retraction week 1 and 2, please. Untie it.
Here.
You have another one right there. So you're the therapist. Show the patient how to do it.
So we're gonna do it just, yeah, we're just gonna do scap.
Good. Make sure the patient's shoulders are relaxed. They don't have to go all the way back. They could stop here and then squeeze the shoulder blades. Okay, good. That is scapular retraction week 1 and 2. And then how would you progress to scapular retraction? Week 3 and 4.
We're gonna do the eye wide, so
T's wise and eyes wise.
T-Y.
It doesn't matter which of the order is.
the left hand.
Doesn't matter.
This is my left hand.
All right.
So to have them, we're gonna do keys,
So again, assume the patient doesn't know what they're doing.
Okay.
So yeah, you're making that, and you make sure, I do it for the first time. I take my hand, I put it on their scapula, go, and I actually show them what I'm expecting. Otherwise, how are they gonna know what's going on? And then that's the T, you see that scapular retraction. Show me a Y.
and then we're gonna go to Y position and go up.
There you go.
Yeah. we're
And
gonna go
Carlos and I
up.
say Y is really not a scapular retraction exercise. We think an I is really a shoulder flexion exercise.
You ready?
Yep, and-
I guess if you're retracting, do an I, but yeah, those are good. Excellent. All right, now, shoulder internal rotation. Show me a week 1 and 2, and then progress to a week 3 and 4.
Look at that guy.
Oh, sorry.
So,
I thought you needed someone to grab the weight.
thank you. So we utilize the TheraBand.
Well, let me get you a towel.
Use my sweatshirt.
I don't-
Thanks.
All right, propping
We
the
got it.
elbows so we don't
We
put
got it.
any. Ah,
Nice catch. Yeah, I'll take that.
there's no excessive pressure on the brachial plexus. Demonstrating for the patient.
So we're doing internal rotation?
Mhm.
Good. This is internal rotation week 1 and 2,
90-degree
90 degrees, and they are going into their gut,
towards their belly button.
and they're coming out. Good. Very good.
This
And-
range right
And
here.
what is an internal rotation progressing week 3 and 4?
Then he's gonna take a knee.
He's gonna take a knee, all right.
We're gonna face the audience.
This is
Bring
creative.
your arm at 90 with the band. And then bring it forward.
Good. You see that's progression. Very good. Now show me internal rotation week 1 and 2. Yeah, I think you're doing a great job, so continue to teach the patient. Show me internal rotation week 1 and 2, and then internal rotation week 3 and 4.
I think he just did internal rotation.
Oh, external, sorry,
Oh,
external.
external, so he's gonna face this way and bring the band out. So that we're gonna go from belly to 90. To here.
So that's week 1 and 2, good, and then week 3 and 4.
3 and 4, he's gonna go down on one knee once again, facing the wall. So keep this knee up. Yeah. And then we're gonna pull back. 90 and pull back.
Good, 3 and 4, very good. Now, core strengthening, since they have a weak core, which is essential for overhead, right? What is a,
This is the easier one.
you got somewhere to be tonight?
No.
Because you want to run and you want to run.
Yeah.
He's just following orders.
Okay, so we went ahead and this is a variation of dead bug. Easiest would be the legs would be down. Arms are both toward the ceiling, right, perpendicular to the floor. And when this one comes, let's say we're going right arm, left leg. It's gonna come up there, 90-degree bend in the knee, only moving the hip joint. And then contralateral. So the down position for the
Isn't
legs.
Let's
the?
see him do a few.
I thought it was the.
Yeah.
That's okay.
Yeah, it's backwards.
We're doing a different one.
But the main part is that his scapular is,
Yeah.
Different variations.
uh,
Progression.
The main thing that the scapula is when the scapula is on the table, he's not engaging his core as much. So that's
We
a
started
good,
with easy.
that's a good easy one. And then what's the progression?
This is the.
Here's the progression.
We're
This is
gonna
the,
do bear walk, but you guys already saw that.
all right, so this is 3 and 4.
Yeah, this is 3 and 4. Either we can do stable plank, and if we have one a little more dynamic, we can also do like bolster clocks.
All right, I'll buy that. I'll buy that. Scapula's engaged, off the floor, dynamic. You're not just standing. I like it. Very good. Now, how about serratus anterior? Start with open chain, week 1 and 2, and then progress to closed chain, week 3 and 4. Thank you, Kat.
I'm just gonna punch this guy.
Good. Elbows are straight. Very good. That's the open chain, week 1 and 2. And how do we progress in the closed chain, week 3 and 4?
So he's gonna be out.
Kat, you hit him back. No, go.
Do it.
So you're gonna be like a.
Jesus.
And you're just gonna project your shoulder. And
Yes,
down.
that's closed chain,
Camel
as you
back.
guys, as you guys did. Very good.
Or band if needed.
Yeah. All right, now. Now we're up to week 5 and 6. You guys are such great PTAs. Your patient is really doing well. So show me a sports-specific exercise you could play with your patient. Remember, the patient plays volleyball, wants to return there.
Oh, okay.
This is just
Oh.
our can you hold it like in an incline? This is our pretend like plyo, whatever. They're gonna do it and then catch it back if it comes back.
Overhead one hand overhead throw with the
I could catch it if you throw it to
Trampoline.
me like that.
All right.
Oh.
And then how do you? Let's say they want to. Let's say they want to practice here. They want to practice spiking the ball. Who's the patient?
Oh
Gus.
yeah. Matt,
So I'm gonna tell the patient, and I do this all the time. I'm gonna throw the ball. You're gonna spike it to the ground. Jump. You have to, that's not how they play volleyball. Pretend you play volleyball. You can't. Yeah, something along those lines, right? That's sports specific, right?
Okay.
Good. All right. Now stretching progression. How are we gonna? So the posterior capsule is tight, right?
Stretching?
How are we gonna stretch to do the posterior capsule?
Here's the first one.
That's the
On
the
the
cross
chest.
body stretch gets the posterior capsule. You see that? If you don't see it, do it.
Is,
Ah, oh, Carla's favorite.
No.
Oh.
Shoulder down,
If
back.
you're not pinning the
Yes.
scapula, right, and you just bring the arm across, then what's happening to the scapula? It's
Nothing.
moving with you, right? So if you
Better
pin-
demonstration?
If you pin the scapula
Ah,
and now perform the stretch, you stop it from moving.
very good. Cross body stretch. Now, how about in side lying? I even wrote hint, sleeper stretch or a Carlos friendly alternative.
Carla's favorite.
I said a Carlos friendly alternative.
Silent on the effective.
What's the
arm.
alternative?
90
Is that-
reduction.
And then, so you're
Oh,
pushing
right.
into internal rotation, thus stretching. And how long do they stretch for in general?
30 seconds,
30
30
twice a week.
seconds,
I
2
mean,
3 times.
Twice a
60
week?
seconds. Twice
All right.
Twice a
per
week.
session.
Now,
Twice per session.
how could they stretch their inferior capsule on their own?
Inferior capsule on your own. Oh yes, the child's pose.
So show us child's pose.
Table.
Do it on the table, please.
Go.
Child's pose. Boom, boom.
Boom,
That's
boom.
stretching the inferior capsule.
Face down.
Very nice.
All right. Finally, now for the joint move. What joint moves do you perform to stretch the posterior capsule? Now, the group had a very good point. They were thinking anterior glide because internal rotation is limited, right? But think about this. If I do a posterior glide, what part of the capsule am I pushing on? If I do a posterior glide,
Pushing on
I'm posting on no. What part of the I'm doing a posterior
Oh,
glide.
jeez. I'm sorry.
No, but what part is being pushed on? I'm pushing on I'm literally, my hand's on the anterior side, but my force is going posteriorly. So what part of the capsule is getting my force? The posterior, no.
The posterior.
I am pushing and stretching the posterior side. So, you don't get it? If I want to make the posterior side open up, then I push posteriorly.
The head is pushing the back of the.
When I do internal rotation, they're lacking an internal, right? The head is going posteriorly, so I'm gonna do a posterior glide. But forget about that. If I have, let's say I have a ball, a balloon, and I wanna push it through something, I have to push that way. The back of the balloon, it's a bad example. If you wanna open up the posterior part of the capsule, you have to push posteriorly.
All, Professor?
No.
No.
Imagine it's like this.
It's like a balloon.
Yeah.
You're stretching it more
Yeah.
like this, and you push it to like stretch it more.
So which way did you do it?
Posterior.
Posterior,
And if an inferior capsule's tight, which way do I push?
inferior.
Inferior.
This also stretch.
Posterior, yes, but if I wanna do a joint mob on the capsule, I do a posterior glide, because the posterior part of the capsule is tight. And if I wanna work on the inferior part of the capsule, I do inferior. So the two glides are posterior and inferior, okay?
Yeah.
And now, finally, and there's 3s and 4s, not 1s and 2s, because this is aggressive. Finally, modalities. You're gonna use laser to the anterior part of the shoulder to improve function and reduce pain. How would you set the laser parameters?
6 joules with a constant setting. This would satisfy both soft tissue and muscle.
So 6 joules.
Parameters.
Very good.